let's get started. So myocardium, this is our heart muscle. Again, myo means muscle. Cardium is referring to the cardiovascular system. So what are some characteristics? First, we want to understand that the myocardium is the heart muscle capable of contraction and force generation and initiating impulses, so autorhythmicity, so controlled by intrinsic control. Intercalated discs, so that's kind of our first characteristic of the myocardium. What are these discs? They allow impulses to control and spread from one fiber to the next. So this is different from skeletal muscle because we said that the endomysium, the layer of connective tissue deep inside the muscle, prevents the spread of impulses from traveling from one fiber to another. We said that allowed for fine motor control. But if you think about the heart, it does not need fine motor control. So these intercalated discs actually allow the signal, and the signal is the action potential, to travel across the entire mitochondrium. So leaky portions of the membrane just means that the signal can travel through and activate multiple cardiac fibers. So what do these discs allow for? Something called syncytial contraction. So syncytial contraction, we can read, ability of the myocardial fibers to contract simultaneously. So this enhances the heart's ability to act as an effective pump because individual cardiac fibers actually generate very little force on their own. Similar to a muscle fiber, when we activate one muscle fiber, that does not produce a lot of force. Same with one cardiac fiber, but syncytial contraction of the myocardium allows for simultaneous contraction. So if you look at a beating heart, it contracts all together, and that's due to our syncytial contraction. So what are some other characteristics here? So myocardial fibers, there's just one fiber type. So unlike skeletal muscle that has multiple different subtypes of fibers, which we know is type 1, type 2A, and type 2X, myocardial fibers are just one type. So they act like a type 1. They are not considered type 1 fibers, but they kind of act like a type 1 fiber. Why do they act like a type 1? High mitochondrial density, so they produced exorbitant amounts of ATP in a very extensive capillary network. So the heart receives lots of blood flow. The capillaries within the myocardium are extensive, allowing for oxygen delivery, ATP production, and it undergoes aerobic metabolism. So these fibers, again, they're not a type 1, but they are similar. They all have type 1 characteristics. They undergo aerobic metabolism. So all these characteristics allow the heart to function efficiently and pump blood for 24 hours for 7 days a week for the entire lifespan of an individual, because our heart never stops pumping. So you can see how it would need those type 1 characteristics to be effective and efficient. All right, so I think that was answering, I think we just answered number 3. Now we're answering number 5, the last question, talking about left ventricular hypertrophy. So first, just in general, the left ventricle is the largest chamber and it has the greatest wall thickness and mass. And we see in this picture down here at the bottom, this is a hypertrophied left ventricle. So you can see the wall thickness and mass is greater. Let's talk about how does this happen. So we have two, I guess, kind of factors that would increase left ventricular wall thickness and mass, and that's regular physical training, such as exercise, and chronic hypertension. So that's going to result in thickening of the left ventricular wall and an increase in its mass. Let's talk about why that is. So the question I would normally ask the class is left ventricular changes in an athlete compared to a hypertensive patient. So how are they similar versus how are they different? So with exercise training, we think about lifting weights. We think what happens to our cardiovascular system. Well, our blood pressure increases. Same with aerobic training. Blood pressure increases, heart rate increases. And so to overcome those high blood pressures, the left ventricle will adapt, and it will thicken. So what does this allow for? The ejecting of more blood out of the aorta. So ejecting more blood, more forceful, pumping more blood basically to the entire body. Let's talk about now a hypertensive patient. So hypertension means chronically, or high blood pressure that's chronic. So the difference here is an athlete, their blood pressure will go back down after they stop their workout. But a hypertensive patient, their blood pressure will not return to normal. So both these two individuals would have hypertrophy of this chamber. But again, the hypertensive patient, this is not necessarily a good thing. Why is that? Because the left ventricle will increase outside or above normal limits. What are normal limits? 33 millimeters is kind of that wall thickness. So going above that would be considered abnormal. And that's what the chronic hypertensive patients would experience, where with the athlete, the ventricle is still within normal limits to be considered healthy. So let's talk about the benefits of this. It is a positive adaptation for athletes. Increased force of contraction allows more blood to be pumped to the body. If more blood's pumped, there's more oxygen delivery. Again, just remember with the athlete, it's within normal limits, where with the hypertensive patient, it's outside of that. Another fact is that it takes about 6 months of, high intensity training for this adaptation to occur. Next, let's talk about why does the atria, so both the right and the left atria, which are our top two chambers, and then our right ventricle down here at the bottom, why do these three chambers not increase in wall thickness or mass? So normally I would have the class come up with a reason for this. So let's start with the atria. Why do the two atria, why do those chambers not change? The answer is they only receive blood. They're only receiving blood from either the lungs or from the body. So with that receiving, they only have to pump blood to the chamber right below them. So they're just pumping blood right through one valve into the ventricles. So that distance is not very far. So we're not having to pump blood to the entire body. We're just passing blood to the next chamber. So that's why the atria do not see additional changes. But now let's talk about the right ventricle. So the right ventricle, it does pump blood. Where does it pump blood to? To the lungs. So we actually don't need additional force coming from that right ventricle. We don't need kind of an explosive pumping action to go to the lungs. But we do need an explosive pumping action to pump blood to the body through the aorta. And so that's why the left ventricle would change, but the right ventricle would not, because it's only pumping to the lungs. And the lungs are in very close proximity to the heart compared to all of our muscles and organs, which are further away from that pumping action. All right, so let's get into some of our variables that we will kind of discuss throughout the next few slides. First term being cardiac output. You'll always see cardiac output in these slides as Q. Q is the abbreviation. And what is our definition? So amount of blood pumped per minute. Minute is kind of the key here. Usually cardiac output is measured in liters per minute rather than milliliters per minute. Cardiac output is an important indicator of how efficiently the heart can meet the body's demands for perfusion. What is perfusion? The delivery of blood to a capillary bed in a tissue. So it's basically a measure of the rate of blood flow. Cardiac output is the same in all individuals. And so that one's kind of interesting. Average cardiac output for a male is about 5 liters per minute. cardiac output for females is about 4.5 liters per minute. So very close. So on average, you do need to know that cardiac output is roughly about 5 liters per minute. Cardiac output is determined by heart rate and stroke volume. So now let's talk, what is stroke volume? You can see there, we're also looking at the amount of blood pumped, but now it's per beat. So per contraction of the heart, how much blood is ejected out of the left ventricle. And so that's a measure of stroke volume. So stroke volume is, we get cardiac output by multiplying heart rate times stroke volume. So let's do an example. So first, average stroke volume, let me just tell you, for males is roughly about 70 to 80 milliliters. And yes, stroke volume is measured in milliliters compared to liters. And then in females, it's about 60 to 70 milliliters. So here's our example. We have, let's say, average heart rate is about 60 beats per minute. And then we have stroke volume, we're going to look at a male, is about 80 milliliters. So when we multiply those together, we get 4,800 milliliters. But like I said, cardiac output's usually measured in liters, so we would have 4.8 liters would be the cardiac output. So that's going to be about average, but that's going to be kind of closer to an average for a trained person. And we'll kind of get into that on these next few bullet points. So we have a point right here, which I already mentioned, is resting cardiac output is about the same in trained and untrained people. So regardless of your training status, if you've never trained, never exercised in your life, versus if you consider yourself to be highly trained, you and that other person have a very similar cardiac output. So somewhere around 4.5 to 5.2 liters of blood. So what's the difference between these two people? If it's not cardiac output, it's gonna be heart rate and stroke volume. So how do we figure this? A trained person is going to have a lower heart rate and a higher stroke volume. And then an untrained person is going to have a higher heart rate and a lower stroke volume. These values will be resting values. So at rest, the trained person has an increased parasympathetic tone. Parasympathetic tone is just a decreased heart rate at rest. So like we said bradycardia, less than 60 beats per minute, would be very common in a trained person, whereas they would have a higher stroke volume. Higher stroke volume at rest may be closer to the 70 to 80 milliliters of blood. This again is due to being able to pump more blood to the muscle. And then an untrained person would have a higher heart rate at rest, so maybe somewhere around 70 to 80 beats per minute, and then a lower stroke volume. Another reason that stroke volume is lower in the untrained person, because the heart is not as efficient, not able to pump as much blood to the heart. So lower stroke volume, higher heart rate. When you think about those values, one being higher, one being lower, that's going to even out and give us about the same resting cardiac output. So during exercise, what happens to heart rate, stroke volume, and how do they affect cardiac output? And this one's pretty obvious. Acutely, all those values will increase, no matter how trained or untrained you are. So when we start exercising, our heart rate increases, heart rate gets higher, our stroke volume gets higher, which increases our cardiac output. So we have more blood being pumped to the body. So how much do these variables increase? Heart rate will increase about 3 times the rested state. Stroke volume will increase, but then it's going to plateau at about 40 to 50% of VO2 max. And then cardiac output is shown to increase by about 4 to 7 times resting. So during exercise, cardiac output can be anywhere from 20 to 35 liters per minute, and that's blood being pumped. So here's a quick video.
With each contraction of the ventricles, blood is pumped out of the heart. Stroke volume is the amount of blood a ventricle pumps out in one contraction. Cardiac output is the volume of blood that each ventricle ejects every minute. To find the cardiac output volume, multiply the number of heartbeats in 1 minute by the stroke volume. At rest, the cardiac output for an average adult male is about 5.25 liters, 4.9 liters for an adult woman. Cardiac output increases with physical activity, rising to a maximum that may be 4 to 7 times greater than the resting output. This difference between resting and maximum output is known as cardiac reserve. Heart rate and stroke volume are regulated by the autonomic nervous system and by hormones in the bloodstream. Other factors such as age, weight, and physical fitness also influence cardiac output.
Let's continue talking about the relationship between heart rate, stroke volume, and cardiac output. So we see here that any change in our heart rate affects cardiac output. So it's a direct relationship between the two. If stroke volume remains unchanged but changes in heart rate occur, then cardiac output will increase, and vice versa. So let's say the heart rate stays unchanged but stroke volume increases. All of those changes will kind of result in a change to cardiac output. Some other terms here. So next term we have to be familiar with is end diastolic volume, so EDV. So we read our definition: blood in the ventricles at the end of diastole. We remember diastole, which is the filling or the relaxation phase. This is before the blood is pumped out. So we have our ventricles and we have blood filled in both of them. So end diastolic volume, or EDV, is just how much. So looking at the volume of blood that was filled. So if we have an increase in end diastolic volume, I want you to think about what else will also increase. So if we have more blood filled into the ventricles, what else will change? Stroke volume. So if we have more blood that filled in that resting phase, we're going to have more blood pumped out of the ventricles. So we're going to have a greater stroke volume, because stroke volume is the amount of blood pumped per beat. Another term here is end systolic volume. So this is the blood in the ventricles at the end of systole. So this is after the blood has been pumped out. So this is kind of like your residual volume. This is what is left over. So it's what's left over after the heart contract. Interesting enough is we don't pump out all of the blood in the ventricles. There's going to be a little bit left over. So let's kind of look at some variables here. So we have our equation. So we have end diastolic volume minus end systolic volume. We take what we had filled minus what was left over. That gives us how much was pumped out, and that's what stroke volume is. So let's say we had 120 milliliters of blood in end diastolic volume. That's how much blood we had filled into the ventricles. And then we have 40 milliliters that was left over, 40 milliliters of blood that did not get pumped out. But that tells us what our stroke volume is. Stroke volume being 80 milliliters. We could do the same thing. Let's take an average female. So let's say her end diastolic volume was 40 milliliters. 40 milliliters filled. And let's also say there was 40 milliliters that was left over. So that gives us 60 milliliters stroke volume. And so those numbers are kind of around the average, anywhere from 60 to 80. So one more picture here that just kind of shows these three variables together. We have before contraction, let's say we had 110 milliliters of blood. And then we have in systolic volume, we have 40 milliliters that was left over. That's going to give us 70 milliliters of blood that was pumped out. So stroke volume, 70 milliliters. This is called our preload when we look at end diastolic volume. So what is preload? Preload is the end diastolic volume. The amount of blood in the ventricles is going to stretch those myocardial fibers, or those ventricular fibers. So it's going to stretch it to its greatest dimensions. When it stretches it, that stretching causes a greater contraction. So think about a rubber band. When you stretch a rubber band, it's going to snap back really fast. We talked about this with muscle tissue. So when we stretch the ventricles, those fibers are going to snap back and eject more blood out of the heart. And then we have afterload. Afterload is pressures that the heart chambers must generate in order to eject blood out of the heart. So the pressure against which the heart must work to eject blood during systole. So we're going to stop this video here, and you can finish the rest of part 2 in this